Pathological jaundice, prehepatic, hepatic and post-hepatic jaundice are discussed under pathological jaundice. Firstly, prehepatic jaundice, which is otherwise called as hemolytic jaundice. So in this type of jaundice, there is increased breakdown of hemoglobin to bilirubin at a rate in excess of the ability of the liver cell to conjugate and to excrete. So there is increased RBC lysis, leading to increased hemoglobin production, causing increased bilirubin. Now this bilirubin increased content is beyond, that is more than the liver ability to conjugate and also to excrete. So there are many causes for prehepatic or hemolytic, some of which are some genetic causes like sickle cell anemia, thalassemia, G6PD deficiency, and some infections like malaria and sepsis, incompatible blood transfusions, autoimmune disorders, all of which will cause increased cell lysis, RBC cell lysis, producing more and more of hemoglobin and more of bilirubin. Now, the clinico-biochemical findings in this type of jaundice is there will be yellowish discoloration of eyes, and because there will be increased RBC lysis and increased bilirubin production, ultimately that there will be beyond the ability of the liver to conjugate. This bilirubin that is produced is beyond the ability of the liver to conjugate. So as a result, there will be more of unconjugated hyperbilirubinemia. And this unconjugated bilirubin in serum, when it is tested for Vandenberg, it gives indirect positive result. And when compared to normal, this increased bilirubin, when converted to urobilinogen, this urobilinogen is increased in amount in urine when compared with normal. So urobilinogen in urine and also in feces, these are increased in amount when compared with normal. And one important point to remember here is there is absent bilirubinuria, that is the conjugated bilirubin in urine is absent. There will be more of unconjugated bilirubin, but this conjugated bilirubin as such in urine is absent. That is one important point to note in prehepatic or hemolytic jaundice. Next, coming to hepatic or hepatocellular jaundice. Now this occurs because of liver diseases as such. In these liver diseases, there will be hepatic parenchymal cell damage. Now this hepatic parenchymal cell damage impairs the uptake as well as conjugation of bilirubin. Because of this hepatic parenchymal cell damage, there will be impairment in the uptake and conjugation of bilirubin. Coming to the causes, there are many causes, some of which are infections like viral hepatitis, exposure to toxic chemicals like alcohol, chloroform, carbon tetrachloride, and some drugs and cirrhosis. Now, clinico-biochemical findings, the patient will be having yellowish discoloration of eyes and skin, and there will be increase in the levels of both conjugated as well as unconjugated bilirubin, because some part of the liver will be working normally and some part of the liver will be diseased and there will be parenchymal cell damage. That damaged liver will not be able to conjugate the bilirubin. So because of which there will be increase in unconjugated bilirubin, whereas some part of the liver will be functioning very much normal. So because of which there will be increase in conjugated bilirubin. So as a result, combination of both conjugated and unconjugated bilirubin in serum will give a biphasic Vandenberg test positive. And coming to the liver enzymes, especially the AST and ALT are elevated. AST and ALT are the enzymes markers for hepatocellular injury. These are the marker enzymes for hepatocellular injury. So AST and ALT will be elevated. And in hepatic jaundice, we can see bilirubin in urine. The bilirubin in urine is present. The conjugated bilirubin will be present in urine, whereas the urobilinogen, coming to the urobilinogen that is coming through the feces, the first in the early cholestatic phase it will be increased, but later because of the inflammation and obstruction the production will be low. And as and when the disease is cured and the inflammation is subsided, urobilinogen will again reappear in urine. So this reappearance of urobilinogen in urine is an earliest manifestation of recovery. And bile salts and bile pigments are present in urine. As such, normally bile salts and bile pigments are absent in urine. They are present only in bile. So if these bile salts and bile pigments are present in urine in case of hepatic jaundice. Next is post-hepatic or obstructive jaundice. So this occurs when there is an obstruction in the common bile duct that prevents the passage of conjugated bilirubin from the liver cells to the intestine. So the liver cells from the hepatocytes to the intestine, the conjugated bilirubin is obstructed. The passage of conjugated bilirubin from the liver cells to the intestine is blocked. Now this blockage occurs due to many causes. Some causes are blockage of the common bile duct by gallstones, carcinoma of the head of the pancreas, and carcinoma of the duct itself. Now these causes can again be divided into two types: intrahepatic obstruction or extrahepatic obstruction. Chronic active hepatitis, biliary cirrhosis, lymphomas, primary hepatomas, obstructive stage of viral hepatitis, all of which come under intrahepatic obstruction, where the obstruction is present in the liver itself, whereas the extrahepatic obstruction is where the obstruction is present outside the liver. So stones in the gallbladder, carcinoma of the head of the pancreas, enlarged lymph glands in the porta hepatis. Coming to the clinico-biochemical findings, there will be yellowish discoloration of eyes, skin, and in addition the patient also has nausea and anorexia. And because there will be complete obstruction, there will be cholestasis. There will be cholestasis, which is the stagnation of the bile, and this cholestasis results in pruritus, which is otherwise nothing but itching. And because this conjugated bilirubin is not getting secreted into the intestine from the liver, there is a obstruction at that level. The conjugated bilirubin is not getting secreted from the bilirubin into the intestine. So increased conjugated bilirubin in the serum will cause direct Vandenberg test, and the enzymes, especially GGT, gamma and ALP, alkaline phosphatase, these are elevated in obstructive jaundice. So GGT and ALP are the enzymes for obstructive jaundice. These are the marker enzymes for obstructive jaundice. And also there will be conjugated bilirubin present in urine. So conjugated bilirubin will be present in urine. Conjugated bilirubin is present in both hepatic as well as obstructive jaundice, but it is absent in pre-hepatic jaundice. And because of the obstruction at the level of the intestine, conjugated bilirubin will not pass into the intestine. So urobilinogen is completely absent. Obstructive jaundice, urobilinogen is completely absent, and bile salts and bile pigments are present to the maximum extent. Bile salts and bile pigments are present in increased amount. So this was about prehepatic, hepatic and obstructive jaundice causes and the clinico-biochemical findings.